Hey everyone, welcome back to my channel. I'm Sheila G, the PAC, and today's going to be all about the most common type of skin cancer, basal cell carcinoma. Before getting in, of course, don't forget to like, comment, and subscribe to my channel for all things dermatology. Let's go. Basal cell carcinoma is the most common type of skin cancer. In fact, it's actually the most common type of cancer in humans overall. This cancer originates from the basal layer of the epidermis, which is the lowermost layer of the epidermis. Let's briefly review the anatomy of the skin to get a better idea of where these cancers come from. So the skin is divided into three main layers. You have the epidermis again, which is the top layer of skin. You have the dermis, which is the middle layer. And then you have the hypodermis, which is the fat layer. Another name for this is the subcutaneous fat layer. If we zoom into the epidermis more closely, we'll see that this layer is actually made up of 5 additional layers. So from the top, we have the stratum corneum, stratum lucidum, stratum granulosum, stratum spinosum, and stratum basale. So that last layer, also called the basal layer, is where new skin cells develop, and then they slowly make their way up the epidermis, eventually to the stratum corneum, where they're shed. And that basal layer is where basal cell carcinomas originate. So how does somebody get basal cell carcinoma? The most common risk factor, of course, is sun exposure. And interestingly, basal cell carcinoma is more associated with intermittent sun exposure rather than cumulative sun exposure. And what that means is that short bursts of high UV radiation is more damaging than prolonged sun exposure over time in terms of the development of basal cell carcinoma. People who have light skin phototypes, such as those with red hair, freckles, who cannot tan, are at higher risk of developing this type of skin cancer. However, there is a form of basal cell carcinoma known as a pigmented basal cell carcinoma that's more common in those with darker skin types, but we'll get into all that shortly. Other risk factors include organ transplantation, a weakened immune system, and various rare genetic syndromes. The good news about basal cell carcinomas is that they very rarely metastasize to other organs and tissues, and so they're almost never deadly. However, if left untreated, basal cell carcinoma can be very locally destructive to the skin. Now let's get into the subtypes of basal cell carcinoma and what they look like. The most common subtype is called nodular basal cell carcinoma, and these present as a dome-shaped papule on the skin that is pink, pearly with this shiny appearance, and kind of this overlying collection of blood vessels known as telangiectasia. Now, one of the key features of these is a rolled border. So it kind of has these puffy rolled edges. And these lesions very often bleed spontaneously, and they can start to ulcerate. Now, nodular basal cells typically involve the dermis, again, which is that middle layer of the skin. In patients who have darker skin types, such as those of Hispanic, Asian, African American, or Indian descent, we may even see pigmented basal cell carcinomas. Now, pigmented basal cell carcinomas also have that dome shape, kind of pearly, shiny appearance with rolled borders. However, they have focal areas of pigment within the lesion, and these focal areas can be brown, black, bluish, and even gray in color. They're the same in that they can grow and they can ulcerate and bleed, but these can easily be mistaken for benign lesions, such as a mole, or an age spot known as a seborrheic keratoses, but these are in fact a type of basal cell carcinoma. The second most common type of basal cell carcinoma is a superficial basal cell carcinoma, and these account for about 30% of all basal cells. Now, these spread more horizontally along the surface of the skin and are typically confined to the epidermis, but they have the potential to penetrate into the dermis. Now, these are interesting because these look more like a pink, red, kind of scaly patch on the skin, and they can easily be confused with something like a patch of eczema or even psoriasis. A more aggressive form of basal cell carcinoma is an infiltrative basal cell carcinoma. Now, these can be well defined like a nodular basal cell, or they can be harder to define with areas that are kind of raised, some that are depressed in the skin, and they can erode, they can crust, and bleed very easily due to that abundance of superficial blood vessels. As you can see, these can become very destructive and grow quite large on the skin. Now, because the borders can be hard to define, these have a higher rate of reoccurrence after removal. Another aggressive form is a sclerosing basal cell carcinoma. Another name for that is fibrosing or even morpheaform basal cell carcinoma. Now, these can be tricky and hard to catch because these don't look like your typical basal cell carcinomas. These actually look more like kind of like a depressed scar in the skin, and they can be more white or flesh colored, and they can have areas of induration, meaning thickness, and areas that are more kind of atrophic or kind of thinned out on the skin. And so they can be kind of hard to detect, and so a thorough exam is always very important. Now, these are considered more aggressive too because of their higher rate of reoccurrence, and they can just penetrate into the deeper layers of the skin a little bit faster, so they're pretty destructive. Now let's go over the treatment for basal cell carcinoma. Once a basal cell skin cancer is diagnosed, typically via a skin biopsy, the treatment really depends on the type of basal cell carcinoma, the size, and the location. Now, generally speaking, small, well-defined nodular basal cells that are located on the trunk or the extremities are typically removed through a standard excision in the office, where we take about 3 to 4 millimeters, those margins on each side of the lesion, and then we do an elliptical cut and we close it linearly. So it's closed in a straight line. But for basal cell carcinomas that are larger, more aggressive, and or in high-risk areas such as the face, the ears, the scalp, the hands, or in areas of high tension such as the lower legs, the best way to remove these is through Mohs micrographic surgery. Now let's talk about Mohs. Not that Mohs, but Mohs micrographic surgery. So Mohs surgeons employ a tissue-sparing technique. And what that means is that the Mohs surgeon is going to go in and remove that area of skin cancer without taking any wider margins initially. And then what they do the same day in the office is they take that skin specimen and they look underneath the microscope and use various stains to see if the skin cancer has been totally removed or if there's any positive margins. Now, let's say there were some positive margins in one particular location. Then they're going to mark that area, and then they're going to go back to the patient and remove additional skin within that indicated area. And they repeat this until the skin cancer is totally clear. Now, Mohs is utilized again as a tissue-sparing technique, meaning they take the least amount of tissue possible because, again, remember, we're working in areas that are highly cosmetic, complex, such as the face, the ears, the hands, or in areas of really high tension, like the lower legs, that can't be closed with a standard excision. So from experience, Mohs surgeons are highly trained surgeons, and their work is incredible. I have a lot of patients where you can't even tell that they had a Mohs surgery. Also, for any providers out there that might be watching this, if you have a patient that has a basal cell carcinoma or a squamous cell carcinoma and you're not sure if they would require Mohs, there is an app called Mohs AUC, and this is where you can input all the details regarding that skin lesion, and it will give you a qualifying score that will tell you if Mohs is appropriate. For example, let's say we have a patient that has a basal cell carcinoma located on the neck. So that would be area M. And it's a primary lesion, meaning it wasn't treated in the past, and it's a nodular type. So let's say the lesion is about 1.5 centimeters in size and the patient is healthy. So as you can see, the Mohs score here is 8. So Mohs would be appropriate in this case. Now, for superficial basal cell carcinomas that are located in low-risk areas, again, such as the extremities or the trunk, we may opt for a procedure called electrodesiccation and curettage, where essentially we use a device called a curette to basically scrape the top layer of skin, and then we go over that with a hyfricator, where we use cautery to essentially burn that layer of skin. And this is repeated in about 3 to 4 passes in all different directions. Another option is topical imiquimod. Another name for this is Aldera, which can be applied to superficial basal cell carcinomas about 5 times per week for about 6 weeks total. Another thing that can be considered is Mohs for superficial basal cell carcinomas if they're in high-risk areas, again, like the face or the scalp. Radiation is another option for those with larger, more aggressive forms of basal cell carcinoma who are just not good surgical candidates. Now, for those who have a metastatic basal cell carcinoma, which again is extremely rare, or those who have multiple aggressive BCCs, or those who just are not good candidates for surgery or radiation, there are 2 oral medications that are available, known as Araveg and Adomzo. Once you are diagnosed with a basal cell carcinoma, you are at slightly higher risk of getting another basal cell carcinoma and other forms of skin cancers such as squamous cell carcinoma or even melanoma. So once you have a basal cell carcinoma, it's highly recommended to get full skin checks every 6 to 12 months. So there you have it, basal cell skin cancer. Please stay tuned for my upcoming video all about the second most common type of skin cancer, squamous cell carcinoma. I hope you guys found this video helpful. Thank you so much for watching. And of course, don't forget to like, comment, and subscribe to my channel for all things dermatology. I'll see you next time.